So this patient is asking, for patients who may be eligible for BTK inhibitors, are there specific comorbidities that might contribute to adverse side effects?
Yeah, so we screen all BTK inhibitors have some cardiac toxicity. They have been shown with the second generation BTK inhibitors to have less cardiac toxicity than ibrutinib, specifically atrial fibrillation. So if you have atrial fibrillation, maybe that's a reason why you might go on venetoclax first as opposed to a BTK inhibitor, but it's not a contraindication to getting a BTK inhibitor if the atrial fibrillation is under good control. Other cardiac risk factors would include, difficult to control hypertension at baseline or heart failure. These are all things that might make us think twice about using a BTK inhibitor as our first therapy, because venetoclax has no cardiac toxicities. The other thing to consider is BTK inhibitors all, to a degree, have, and I describe it to patients like an aspirin-like effect on the platelets. They do interfere with platelet binding, so universally patients will note to varying levels, some easier bruising. And if patients are on, because of, say, they've had a heart attack in the past and they're on aspirin at baseline, or what would even be more concerning if they were on, like a drug like Plavix because they've had a stent placed, that would be something that would really concern me, and would definitely push me more towards venetoclax that, again, doesn't have those antiplatelet interactions. Also, patients are on blood thinners because of a history of blood clot or atrial fibrillation. There is the potential increased risk for bleeding and bruising there as well. None of these are absolute contraindications. They're just all what goes into the blender, if you will, of putting lots of information in and coming up with a best treatment decision that's personalized for the CLL patient. We're blessed to have multiple options, but it does make it more of a challenge to find the quote unquote best option.